Physiology Type 2 Diabetes by Jacqueline Jones, MSM 570. Diabetes Case Study Overview. CB is a 48-year-old, significantly overweight woman from the Winnebago Indian tribe, that's in Nebraska, who had high blood sugars and cholesterol levels 3 years ago, but did not follow up with a clinical diagnostic workup. She had participated in the state's annual health screening program and noticed that her fasting blood sugar was 141 and her cholesterol was 225. However, she felt perfectly fine at the time and could not afford any more medications except for a number of female infections. She has felt fine until recently. Today she presents to the Indian hospital general practitioner complaining that her left foot has been weak and numb for nearly 3 weeks, and that foot is difficult to flex. She denies any other weaknesses or numbness at this time. However, she reports that she has been very thirsty lately and gets up more often at nighttime to urinate. She has been she has attributed these symptoms to this extremely warm weather and drinking more water to keep hydrated. She has gained a total of 65 pounds since her last pregnancy 14 years ago, 15 pounds in the last 6 months. Past history. Seasonal allergy rhinitis since her early 20s, breast biopsy positive for fibroadenoma at age 30, gestational diabetes with her fourth kid 14 years ago, morning sickness with all 4 pregnancies, hypertension times 10 years, moderate to severe osteoarthritis involving hands and knees, times 4 years, multiple yeast infections during the past 3 years that she has self-treated with over-the-counter antifungal creams and salt baths, occasional constipation, her past surgical history, a C-section 14 years ago, first occurrence of her menstrual cycle was at the age of 12, menopause natural at the age of 46 and a half, problematic hot flashes. She has chosen not to do hormone replacement. She had her first child at 17, her last child at 34, so she's grava 4, para 4, abortion 0. All 4 kids are healthy. The last one weighed in at 10 pounds, 6.5 ounces, and her last pap smear was 4 years ago. Family, family history and social history. Type 2 diabetes presented in her younger sister and maternal grandmother. Both was diagnosed in the late 40s. Maternal grandmother died from kidney failure while waiting for a kidney transplant. Sister is taking pills and shots. Father had emphysema. 2 older siblings are alive and apparently well. All 4 children are healthy. The social history, she's been married for 29 years with 4 children. Husband is a migrant farm worker. Family lives in A family of 5 lives in a 2-bedroom trailer. Patient works full-time as a seamstress in a small family-owned business. She smokes 2 packs of cigarettes per day since the age of 14, and she drinks beer most evenings. Has never used illegal drugs or of any kind. Rarely exercises and admits to trying various fad diets for weight loss, but with little success. Has given up on trying to lose weight and now eats a diet rich in fat and refined sugar. Diabetes, type 2 diabetes. In 2015, type 2 diabetes is the single most common type of diabetes in the United States today. 30.3 million people in the United States have diabetes. 9.4% of the population, approximately 1.25 million American children and adults, have type 1. There is 1.5 million Americans that are diagnosed with diabetes every year. Diabetes remained the seventh leading cause of death in 2015, with 79,535 death certificates listing it as the underlying cause of death, and a total of 252,806 death certificates listing diabetes as the underlying and contributing cause of death. Type 2 diabetes is adult onset diabetes. The underlying pathophysiology is insulin resistant. The risk of developing type 2 diabetes is correlated with the age, obesity, and family history. Type 2 diabetics increase insulin secretion to compensate for peripheral tissue resistance, but eventually this mechanism fails. In, in some cases, type 2 diabetics can burn out their pancreas, thus needing insulin replacement just like a type 1 diabetic. The signs and symptoms of diabetes for type 2 is hyperglycemia. Hyperglycemia has both short-term and long-term complications. Diabetes is referred to as a starvation in the midst of plenty, since despite plenty of glucose, hyperglycemia is glucose cannot be moved into the cells and utilized. Instead, the glucose stays in the blood and gets excreted by the kidneys. Inefficient use of glucose can lead to weight loss and excessive appetite. Elevated blood glucose can predispose to, to, dental caries and increase infections such as vaginitis, since increased sugars provide a medium for bacteria growth. Elevated blood glucose makes the blood hypertonic, creating the osmotic pressure that sucks water into the vascular space. In the short term, the serum hyperosmolarity causes polydipsia, increased thirst, and polyuria, increased urine volume. Because of the hyperosmolarity pulls water into the intravascular space, excessive hyperglycemia can cause massive fluid shift. Pathophysiology of diabetes type 2. In diabetes mellitus, there is either a decrease in insulin secretions or insensitivity to insulin. Without insulin's effects, glucose cannot move into the cell, and hyperglycemia, increases blood sugar, can occur. In type 2 Adult onset diabetes, the underlying pathophysiology is insulin resistant. Insulin resistant refers to when the cells of the body, such as the muscle, liver, and fat cells, fail to respond to insulin, even when levels are high. Type 2 diabetes increases insulin secretion to compensate for peripheral tissue resistance, but eventually this mechanism fails. In some cases, type 2 diabetics can burn out their pancreas, thus needing insulin replacement like a type 1. Presumption diagnosis. Diagnosis of diabetes for 3 years, about at age 45, a native Indian, thirsty, polydipsia, natremia, frequency urination, uh, hypertension times 10 years, multi-yeast infection, blurred vision, fatigue, and overweight. And when the patient presented, her blood pressure was 165 over 100 without orthostatic changes. Weight was 203 pounds. The BMI was 35, extremely obese. The labs, the glucose was 168. The total cholesterol was 246, which was the high risk. The LDL, the good cholesterol, was 28. It needs to be greater than 50 in women. The LDL, the bad cholesterol, it was 169. It needs to be less than 130. The triglycerides were quite high. They were 458. Needs to be less than 165. The A1C was 8.2. The normal should be 3.9 to 6.4. The insulin level was 290. It needs to be between 6 to 35. The urinalysis, the specific gravity was 1.008. The normal is 1.016 to 1.022. And glucose was positive in the urine. Identity risk factors. Family history of diabetes over the age 35, poor eating habits, lack of exercise, sedentary lifestyle, increasing body weight, history of gestational diabetes, and history of delivering an infant with a birth weight in excess of 9 pounds. And with gestational diabetes, diabetes can occur in pregnancy, which is called gestational diabetes. It is normal in pregnancies for there to be some increased insulin resistance. This keeps the mother's blood glucose high enough to make sure that some of the glucose gets into the fetus. Aggregation of insulin resistance can lead to gestational diabetes. And it also said that if um, if a pregnant lady has gestational diabetes and they're on insulin during the pregnancy, it's more likely that they will wind up being being a diabetic and on insulin after the delivery. Metformin. Metformin is the first drug of choice. Metformin is an oral anti-hyperglycemic drug and is only one drug in this class to date. Metformin increases peripheral glucose uptake and utilization, insulin sensitivity, decreases hepatic glucose production, and decreases intestinal absorption of glucose. Together, these actions address the primary pathological defects of type 2 diabetes to improve glucose tolerance and lower both the basal and postprandial plasma glucose levels. Metformin does not stimulate insulin release from the pancreatic beta cells, nor does it produce hypoglycemic except in specific circumstances. Metformin does not cause hyperinsulinemia. Metformin also does not cause weight gain. Often patients lose weight. Metformin also inhibits platelets aggregation and reduces blood vis- viscosity. Because obesity is a major factor in the pathogenesis of type 2 diabetes, this is an important drug of action. Metformin has a side effect of some GI symptoms, and one of them is diarrhea. Sometimes a patient can get diarrhea that can last up to 3 weeks, and we you usually tell the patient don't be alarmed by it, but if the diarrhea becomes liquid, then you have to let your doctor know, because usually time they'll switch it out and they have another form of metformin, which is called XR, it's sustained release, which gives them a little bit of insulin over time. So then that way, when we put them on maximum recommendation of metformin, the normal dose with 500 milligram tablet is 2,500, but as you can see, the 2,550 is because that would mean that the patient is on an 850 tablet and they're allowed to take 3 a day. That's why the overflow of the 50 milligrams. In metformin, the initial dose should be low and titrated, meaning treat to target. And so what happens is you would give that patient a half a tablet before dinner, and that will help the morning blood sugars to come down, where they would take that pill, that half a tablet before dinner for 2 weeks. If their morning blood sugars is still greater than 120, then you would have them to increase to a half a tablet in the morning. After 2 weeks, if their A1C is still, if their blood sugar is still between greater than 120, they will increase it to 1 pill twice a day, and they can go up to 2 pills twice a day, plus extra. So sometimes if wherever they're running the highest at in the morning before breakfast or before dinner, then they could put the 3rd pill, so they can have 500 milligrams. They can have 2 in the morning with their breakfast and 3 at bedtime. Sometimes doctors order it at dinner time also. And they need to notify their doctor for the side effects that they're having. And they do annually monitoring of the renal function, the vitamin B12, the complete blood count, and the ALT. They watch the liver, they watch the vitamin D because of the bones and the calcium, and also the liver function, the kidney function, because metformin can also drop the GFR, which we look at often, because you want to make sure that that metformin doesn't drop the GFR below 40. If it does, then that patient has to be taken off of that. Complications would be medication or exercise induced hypoglycemia, and sometimes the patients wind up getting glipizide. Glipizide is the second line of defense that's used, and what that does, it really can give you hypoglycemia, because patients have a tendency to take the medication and drive without waiting, and waiting for 15 to 20 minutes and eat before they get under the steering wheel. So It's recommended that if your blood sugar is less than 100, that you don't drive at that time. Infection of the bone and the bone marrow. You could have eye disease, cataract, retinopathy, glaucoma, coronary artery disease, a cardiovascular disease, which is a stroke, renal disease, nerve damage, peripheral vascular disease. What is A1C? A1C is the lab test that is taken over 2 to 3 month period, and the A1C is the sugar in the blood is sticky. As the RBCs travel through the bloodstream, they pick up sugar that is there. The A1C test measures how much sugar has attached to the RBCs. More sugar in the bloodstream means more sugar will attach, causing a higher A1C reading. Once the sugar sticks to the cell, it stays there. On average, the RBCs live for about 90 days. Some cells that you have are new cells and some are old. Therefore, your A1C results give a good idea of what your blood sugars has been averaging for the past 2 to 3 months. A normal A1C is 4.8 to 5.6, meaning your average blood sugar that you self-test should run you between 91 to 114. Pre-diabetic is 5.7 to 6.4. The average blood sugar would be 115 to 139, and your glucose and your the diabetic patient would be 6.5 or higher with a blood sugar of 140 or more. Usually time, the way they tell that you are diabetic is if you have 2 fasting glucose tests that come back higher than the 120, or higher than the 120. And then also if you have 2 A1Cs that come in greater than 6.4. If you get 2 of those, then you automatically consider a diabetic. The blood pressure, the medications that the patient is on, she is going to be taking, she is on lisinopril. Lisinopril treats high blood pressure, congestive heart failure, and is used to improve a patient's chance of survival following a heart attack. It also has a protective effect for the kidneys, and it is the first choice of treatment for hypertension. The next one is Norco. Norco is a narcotic. It has 5 milligrams of Tylenol. The hydrocodone is 500 milligrams, and it is used to treat moderate to severe pain. The next one is naproxen, and naproxen is also known by the brand name as Aleve. It's a non-steroidal anti-inflammatory drug commonly used to treat pain, fever, inflammation, and stiffness. The standard over-the-counter dose in the United States for adults is 220 milligrams, while doctor may prescribe larger doses. Long-term doses may risk a stomach ulcer, among other complications. The next one is Prelosec, and Prelosec prevents the production of acid in the stomach. It is used to treat gastroesophageal reflux, ulcers, certain bacteria in the stomach, inflammation of the esophagus, and Zolling-Edison syndrome. It is also used to treat other conditions that cause too much acid in the stomach. And the next one is Colace, a stool softener, is used to treat occasional constipation, Some medications and conditions can cause constipation, and that would be the Norco that would cause the constipation more, more likely. Stool softeners such as Colace are also the first method used to prevent and treat this type of constipation. Colace is often straining, used when straining to have a bowel movement, should be avoided after a heart attack or surgery. And the last drug is Claritin because she had the rhinitis. And Claritin is a long-acting, non-sedating antihistamine used for treatment of allergies. Histamine is a chemical that causes many of the signs and symptoms of allergies. Histamine is released from the histamine storing cell, the mast cell, and attached to other cells that have receptors for histamines on their surface. Histamine stimulates the cell to release chemicals that produce effect that are associated with allergies, including welts, itching, tissue swelling. Claritin blocks one type of histamine receptor, the H1 receptor, and thus prevent activation of cells with H1 receptors by histamines. Unlike other histamines, Claritin does not enter the brain from the blood and therefore does not cause drowsiness when taken as at the recommended dose. Treatment: low blood sugars by prescribing the metformin and treat the target at half a tablet. As I mentioned earlier, uh, you want to check your blood sugar twice a day, before breakfast and before dinner. You want to watch your carbohydrate intake and your fat intake. Daily allowance is 45 to 60 grams per meal. 50 grams will work if you're trying to lose weight. 10% of your body weight will help lower risk of diabetes. Increased fiber will help with digestion and constipation and a feeling of fullness. Help to plan ways to reducing the stress, in turn will reduce the risk of infection and lower the blood sugar. Encourage smoking cessation and address the social economic factors. Cost of medication can impact the compliance. And one thing I wanted to mention was about the immune system affected by stress. Your immune system is your body's first line of defense against invading bacteria, viruses, and other pathogens. Your organs, tissues, cells, and cell products that all work together to fight harmful substances and protect you from getting sick. Stress can affect your immune system in two ways: by creating chronic inflammation that cause harm to the tissues, by suppressing immune cells needed to fight infections. Management: you want to take your medication regularly. You want to check your blood sugars to keep them within normal limits. You want to watch your diet portion, the healthy plate plan. Watch your carb intakes, attend free diabetic classes if you have them in your neighborhood. Good shoes to walk in. Check your blood pressure regularly at a free clinic. And behavior modification for diet and smoking. Thank you.